Hi, everyone. Thanks so much for joining us. We're going to get started in just a minute. Give folks another second or so to join us. Okay, we're going to go ahead and get started. Thank you so much for everyone for joining us today. My name is Madison Hammett, and I'm a policy analyst with the Illinois ACEs Response Collaborative. And we are so excited to welcome Dr. Kim Mann of the Illinois Department of Children and Family Services for shifting the focus, prioritizing the developmental needs of infants and toddlers through early childhood court teams. And just a quick plug, if you're a tweeter, please join us at HMPRG or hashtag ILACES and let us know what you think of the webinar as we go. So for those of us who are joining us for the first time, some quick background on us. Health and Medicine Policy Research Group works to promote social justice and challenge inequities in health and healthcare. We're an independent policy center here in Chicago that conducts research, educates, and collaborates with other groups to advance policies and impact health systems to improve the health of all people. And then here at the Collaborative, we are housed at Health and Medicine, and we are a multidisciplinary group that utilizes the science of ACEs and childhood trauma to create critical transformation to policy and practice and align that with current research. We're a backbone organization, and we mobilize, convene, and advocate to create systems-level change. So if this sounds like something you're interested in, please visit our website for more information, including policy briefs, environmental scans of different trauma-informed programming, and all the webinars we've done in the past. We'd also like to take this time to thank our funders who help support this webinar series. That includes the Illinois Children's Healthcare Foundation, the Otto S.A. Sprague Memorial Institute, the Prince Charitable Trust, and the Albert Pick Jr. Fund. After the webinar, you're going to receive a short evaluation survey, some ways that you can participate in the collaborative, links to our website, and that includes all of those pieces of information and materials I mentioned, and you'll also receive a recording of the webinar. This is a webinar that we want y'all to participate in, so please, if you have any questions or comments you'd like to share, there is a question box at the side of your screen. Oh, jumping ahead there. There's a question box at the side of your screen there, and we would love it if you type those in for us. I'll be monitoring that throughout the webinar, so please have those ready. And we'll have a Q&A session at the end where you can talk to Dr. Mann some more. And to give an introduction to Dr. Mann, we're so excited to welcome her. Dr. Kimberly Mann is the Deputy Director for the Illinois Department of Children and Family Services Office of Child Wellbeing. Since joining DCFS in 2008, she has guided the development of trauma-informed practices, served as Project Director for the Illinois Birth to 3 Title IV E-Waiver, and leads the implementation of the Early Childhood Court Team, which you'll be hearing about today. Dr. Mann has more than 20 years of graduate and undergraduate teaching experience in social work and more than 30 years experience with youth and families, primarily in child welfare, public school, and community settings. And we are so excited to welcome her today. And Dr. Mann, I am going to hand over control of the keyboard and mouse to you so you can get underway. So you are now in control of the computer. So,
you know, I have issues where I like to be in control, so thank you, Madison. And also, it's so funny to hear my bio. I always usually feel like when you rattle off those numbers at the end that I am truly very old. Hi, everybody. Thank you so much for taking out time in your busy schedules to join this discussion. My goal is to run about 30 minutes or so, maybe 35, and then to leave us a nice time for some conversation at the end. I know this is a national webinar, so I'm particularly interested in whether or not we have folks who might already be involved in this work. We'll talk a little bit about how we got here, but I will say that we are relatively early in terms of program development world in this effort, and so certainly there may be folks who've been at this longer or who have the vantage point of other experiences through other states. So I think hopefully we can have a great conversation. I think I'm in control, Madison, but I'm not able to change the slides. So
let me
not sure
see.
what's going on with that.
I will try again. Let's see. There we go. Oh, you should be able to do everything now. Yep. There we go.
There we go. All right. All right.
There might be a tiny bit of a delay on your end, but it looks good from here.
Yeah. Okay, good. So we're going to do a couple of things in this time that we have together. We're going to look at this approach, which is an evidence-informed approach to working with infants and toddlers through a court team model. And we'll certainly do an overview of that and think a little bit about how it might affect both the children, their families, and communities. It is a multidisciplinary team approach, and so we will be talking about some of the ways we've thought about approaching that and some of the challenges that are inherent, which I'm sure many of you can just nod on right now in terms of working across different disciplines as it relates to coming together, particularly within a child welfare context. And lastly, we'll think about how these efforts could, support both prevention efforts. I know our state is actively trying to launch a Family First agenda, which some of you may know is a new way of thinking about funding for child welfare. I think it's very important just to reinforce the good work that our ACE collaborative is doing in terms of helping us to think about how many, if not all, of the families that we are working with currently are challenged by having a great deal of adverse life experiences, which have now resulted in the removal of their children. But I do think that we still continue to have effects on both prevention and public health and changing systems within the community, because we have young parents that go on and continue to have other children, and so there's still that opportunity to prevent further harm for children and for their families. So wanted to just tell you a little bit about our story, first of all, and I could spend a couple of days on this one, but you heard a little bit about the fact that I came to this work in child welfare from a university setting. So I personally came to the work thinking a lot about how we convert theory to practice and some of the challenges and opportunities that are inherent in trying to do that. In the red box there, the first effort I had back in end of 07 into 08 was to try and bring a more trauma-informed perspective to our workforce and to the practice that we do in child welfare. And that took on, as you might not be surprised, the effort was primarily focused on training. And so you'll hear me talk a lot throughout this time together about, some of the advantages and limitations of training approaches, especially where there's not coaching, post-training that relates to really embedding practice changes into a system, into an organization. And so we actually, a couple of years later, beginning in July 1st of 2013, had the opportunity to begin a federal waiver. Federal waivers for 4E through 4E funding are intended to divert funds that traditionally go to board care for children who are in our child welfare system to innovative interventions. And so we were able to do that over a 6.5-year period, that waiver ending on September 30th of this year. And the birth to 3 waiver, which I'll talk more about in detail, at least some aspects of it, really served as the foundation, the building blocks for the court team approach. We saw the limitations first of all, we saw the opportunities and we made great advancements in the work, particularly bringing a couple of evidence-based interventions to our system, as well as the new assessment protocol. But we also were only working with a portion of a case, if you will. And so adopting the court team model gave us the opportunity to work literally what I tend to call A to Z in a case. I will say to you all that while I don't have them listed on the slide deck, both IB3 and the early childhood court team approach from Illinois both have videos on YouTube. And if you were to search under Illinois Early Childhood Court or Illinois Birth to 3 Waiver, you'll find both of our videos. What's happening with my there we go. So when we started this effort, literally back probably in 2011 and 12, when we were doing the planning, we were, the focus of what we would do was very much driven by this data, which has, been in many, many federal presentations as well as local and state presentations. But it really was the problem of, number one, the high number of children that come into care, into foster care, that are under the age of 3. And in our particular state, our challenge was that while we had a limited number of families that come into care, we rank, I think, number 3 in the nation for taking the least number of children into care. Once they get in care, we've had a great deal of difficulty, meeting some of our national partners around their exit from care. So you can see that the problem was particularly dramatic in Cook County, and this just shows you that it takes Cook County about 3 years to get to, at least maybe this has been updated, to where most of the state is in a 2-year period. So it really dramatically showed that we have work to do both in and out of the county, and that was some of the impetus for the IB3 program. This is just more limited because I know that equity is a big part of the work that the ACE Collaborative does, and it is for us in Illinois as well. And I'm only showing you court team data, not statewide data, but you can see that this issue of disproportionality, which is an issue for us statewide, is also an issue for us within the court team model. So you see the representation of families by these kind of basic demographics here, and that African American families are most heavily represented both in this project and throughout the state. So in those two things, both the developmental focus and in this issue of race and ethnicity, we have some opportunities to hopefully make an impact. And the number one thing that was a driver, and I mentioned earlier that I actually, one of my primary areas from a teaching perspective and in some of my research was around trauma. And so continuing those training efforts, we knew, of course, that trauma gets kids off track. It derails development. And it's often, and we're really good about tracking these things, what are some of the traumatic events that have led to children coming into care. But we know through the work that all of us are engaged in that there's an opportunity here. It doesn't have to be the end of the story. And so certainly if we get the right things in place for children and their families, we can get them back on track. So that was actually one of the models of the IB3 program, getting kids back on track. One of the things that we found by tracking trauma experiences was actually a little startling. We only had data prior to beginning, that looked at our children from the National Survey of Child and Adolescent Wellbeing, and we had some Illinois data around that as well. But what we found is that looking at both children's experiences of trauma and their trauma symptoms really didn't start from our data set at the time until age 3. And so the fact that we were working with kids birth to age 3 meant we didn't really know how to predict what our numbers were going to look like in terms of children's trauma exposure. We look at trauma exposure using the Child and Adolescent Needs and Strengths tool, and we look at trauma symptoms or regulatory problems in children using the Devereaux and the Infant Toddler Symptom Checklist. Those are our two primary tools. And you can see in this slide, we are a randomized control. By the end of the waiver, I think we were serving about 2,600 children across the county. And you can see, really very sadly, the high number of kids that have been exposed to what we would call high rates of trauma on the cans, meaning their exposure had been significant. It's always interesting. They haven't been alive long enough for it to have been over any protracted period of time by adult standards, but certainly in the life of a child, that's not true. And so one of the cases actually that we use to illustrate the work that we're doing looks at a little one that came in at the age of only 6 weeks. And she had, substantial trauma history in her little 6-week life, noted by the fact that the doctor said there was evidence of older injury. And I use her case because I was so struck by that terminology from that physician that said evidence of older injury in someone who really hasn't had an older. She was only 6 weeks old. So these numbers is the problem that we were tackling, and I'll tell you a little bit about the ways that we were trying to get there. So one of the things that I'm very mindful of in trying to do this work now over several years within the context of a child welfare system is that not everyone fully appreciates what's going on for little ones. And in some cases, my colleague always says that these are called the easy cases. They say that because if they've got a caseload that includes adolescents, for example, who might run away or get involved in all kinds of, activities that adolescents tend to get themselves involved in, the toddler or the infant, and usually is the ones that it can be the most overlooked, if we want to use that word, can't tell us that they're feeling scared right now because they're in a new place, or that they don't feel safe with this particular person because they just don't know them, that no one has ever, had that gleam in their eye for them. But we were able to build in some tools to be able to look at that, and I shared what those were. So we looked at using both those 3 tools, like I said, the CANS, the DECA, and the Devereaux, and the infant toddler symptom checklist. We attempted to tackle this population of children. We only were looking at the 0 to 3 population, even though children 0 to 5 make up more than 50% of the kids coming into care in this county alone. The services that we wanted to utilize to support them really did focus on both age and stage of life. And our goal was very relational. We really felt strongly that if we gave the caregiver some new tools, we would be in a best position to help those children get on the right track. One of the primary things from a trauma and theoretical perspective that you want to do is to help those caregivers be able to both effectively read, pick up on, respond to things that their baby is telling them, to be more effective in those things. So what magic did we do? Well, I think maybe this is a little out of order, but we brought to the core team model, it's something we did not use in IB3, but we brought to that a trauma-informed perspective, a developmentally informed perspective, a system of care, and we attempt to use family-centered practices. And so, we've talked a little bit about the trauma approach, and I'm going to tell you a little bit about the interventions that are being utilized to address some of those issues. But the developmentally informed approach was not only at the level of IB3 and later court team something that was a priority for the parents and the clinicians that worked with this population, but as we move into court team, it becomes a really significant issue to help attorneys understand, to help judges understand. So a really practical example of that would be, meeting with our judges and talking about the Devereaux and talking about children potentially losing ground and having, showing what we call slides developmentally, where a child might come in showing more protective factors and watching those, actually show some regression or some deterioration, depending on the word you want to use, after things like placement moves and things like that have impacted them. We know for our families that we're dealing with complex families with complex issues, and so we really have to work with the caseworkers, the clinicians, and even the attorneys and judges around wrapping those services around families, bringing people to the proverbial table, which we'll talk more about in a minute, and in a family-centered way, making sure that their social supports are present, that they have their, either building or activating a natural support network that's going to really wrap around that family. And also, as the last point on that, taking into account the family dynamics that make up that unique person's situation. All right, so we believe if you give them the tools, like this little guy has working with his caregiver here, we can really learn to manage those reactions, support folks, and ultimately achieve better outcomes in both permanency and well-being for little ones. So the way we did that, and here's the service slide that I was looking for, is to use really three unique but two related interventions. Many of you on the call may be familiar with child-parent psychotherapy. It is our most intensive, and so we looked at that for that high-risk population that you saw earlier. It is both trauma and developmentally focused, and typically families are treated with that modality for about 12 to 18 months. For our moderate and low-risk parents, which we had very few in the low risk, we used the Nurturing Parenting program, the 0 to 5 version, and that gave us a really, some pretty awesome outcomes, but it also gave us an opportunity to kind of mirror, but yet advance and enhance, I'll say, what families had been getting. People often wanted, parenting approaches are obviously classically used in child welfare, but parent coaching is often a preferred modality in order to be able to apply what you've learned in class. And so Nurturing Parenting gave us both, gave us pre and post testing, and it was just, over the time we've been doing it and continue to do it, has been extremely well received by our agencies as well as by our families. We have several panels over the years that have brought in parents to talk about their experiences with Nurturing Parenting. Because I mentioned the focus around relationships, and so we wanted to be sure that caregivers, foster caregivers in this case, would have the opportunity to also get a dose of good developmental support. And that was a challenge. I'm going to start to weave in challenges as I go along here, but the group is extremely well received. In fact, our retention in the group is above 80%. It's getting them there in the first place that can be a challenge. The fact that it's called Nurturing Parenting can present some challenges for foster parents who say, I'm already a good foster parent, why do I need this? Or I don't have time for this, which is a very legitimate concern in their lives. But we have really been happy to serve many foster parents over the years who have just become champions once they've had this opportunity to not only learn new developmental skills potentially, but to get support from one another, which is important for both groups, the parents and the foster parents, to work with their peers and learn from their peers and get support for what they're doing. So, obviously, for the sake of time, these are the primary core components of the core court team model. I'm going to just hit a couple of these, and I think a couple of them are going to be hit in later slides. But I will say this. One of the challenges of a model like this or a framework like this is that each state then has to figure out what are these core components going to mean for their particular system. So for an example, I'm going to give you just a couple from this one. Judicial leadership. As we began to really implement our child and family team meeting model, which you'll see there as number 8, is work with our judicial leadership to say, we really want to call child and family teams the room where it happens, stealing from Hamilton. And we over time have gotten to a point in our communication between all parties that if something's happening in court, potentially a judge can say to an attorney that's making a particular motion, has that been discussed in child and family team, that room where it happens again? I doubt the judges ever say room where it happens. Maybe they do. But they can, find out if in fact this is a team-based recommendation or motion that's being made, or is this a particular individual party's recommendation. And they can support, as is appropriate legally, when it's appropriate legally, that child and family team. So that's where that leadership, it's an example of where that leadership can come into play. I'm going to move on because I know some of these are hidden in additional slides. So I've talked a little bit about that local leadership. We were very fortunate that Judge Patricia Martin, who is the chief judge of the juvenile court of Cook County, is one of the presiding judges of the early childhood court, and was on board even before we launched, and has brought on another judge, Judge Maxwell Griffin, has also joined our team. Advocacy. So we have a role in all court teams called the community coordinator, but in Illinois we call it the community practice coordinator. And if you recall something I said earlier about the fact that you can't just train people in things, you have to literally support the work at the elbow. And in a big system like a child welfare system, sometimes, folks, that's just reminding people that they ever were exposed to something. It may be highly motivating and they may be highly supportive of certain work, but they literally sometimes just need to be reminded of the work and how you can apply it in a unique situation. So that's one of the features of the P in that community practice coordinator role. They're also, though, out there trying to support finding services for families that are unique, sometimes because we're trying to respond to all of the diverse range of needs that a family may present with. And so they're looking for resources, working with stakeholders, and feeding back information to us on where we may have gaps, which, we're clear about exist not only in Cook County at times, but particularly when families are in outlying Caller counties where some of the resource infrastructure may not be as substantial. Because we have a value for relationships and keeping parents in the parenting role, one of the things that's really, really important is this notion of co-parenting. And so we really want to make sure that we work both through nurturing parenting, through casework, to support foster parents. Sometimes it's a process to get there, but them really being able to hopefully achieve a point in time where they're able to work in a collaborative way to the best degree possible. And obviously that can vary, because of all of the clinical needs and cases. But, little things like if you have a child going to early intervention, why not have mom or dad come to that appointment and learn about that care plan? If you have a child's birthday, the simpler fun things that you don't want to be missed during these critical 3 years of life. So we don't want parents to be marginalized, and we want them to be incorporated to the best degree that we possibly can. Child and family team meetings I've already alluded to, but again, that room where it happens, and in our court team process, we meet monthly for a child and family team meeting. Sometimes it may run a 6-week period once cases are very well established, but it's a heavy burden to meet that frequently. But it's critical because you have this journey that we're walking through where we're holding ourselves accountable for plans that have been made. We are staying, really keeping abreast of what's going on for families, and it has dramatically increased our engagement. Our engagement rate for our families in our court team project, I think there's a data point that's going to come up, is around 86%, unheard of, across our system. So I think this is why, because they know that this team of people, not always perfect, sometimes we have our broken places too, but is going to be there and show up for them and support them in this journey that they're going to make. The next piece is family time. And, we're led by 0 to 3 here and the work that they have given us to say, minimum 3 times a week is what's recommended. We have definitely had to work with our own system internally to understand that that's a goal statement. That means, first of all, a couple different things. It's not just the classic visit at the office kind of time. It does include some of those other occasions where you might go to a doctor's appointment, an early intervention appointment, so that you are physically present with your child. Obviously, when it looks like this lovely picture where dad is reading a book to his little ones, that's a great time to promote, in this case, both attachment and literacy. But it can also take the form where there are issues of distance, where there are issues of other challenges like potentially incarceration, using video equipment like I'm attempting to do to also communicate with children. There's a particular judge, and I'm not going to be able to call her name off the top of my head, but she really promotes a 2-book method where mom and foster mom both have the exact same book, and maybe mom is reading a story to that little one at night. And so we have that both shared parenting and family time interaction that is potentially, something that we would work toward, and that's an optimal example. All right, so I think this is current data, but for family time for us, we still have a lot of our families are seeing supervised visitation, which is often where you start. Some of that's a reflection of us being a relatively new program. We have, I think these numbers are a little different. I think this might be data back from April. But at that point in time, we had about 4 families of our 38 families, I'm sorry. Well, this is unique parents too, so this number's not going to add up exactly. But a lot less had unsupervised. I think that number is at least doubled because we have some people moving into case closure at this time. So unsupervised and overnights, I think both of those numbers are a little bit higher, but you can at least see the general profile. Agency discretion for unsupervised day visits is where, as some things may change suddenly in a case, agency could opt to make some shifts in how often family time is being allowed, if you will. And also agency has discretion for some overnights in some of these cases and with some of the individual parents. So this is some of the challenges I just want to speak to for just a moment. And, it really speaks to trying to put forward such an aspirational approach. I remember some of the wonderful feedback of year one of, people really, we all came to this work with great hopes and aspirations for what we could accomplish. And so we have this combination of, knowledge that is, definitely increased through a lot of the ongoing training efforts that we do in this approach. We have our own, and our families have their own ACEs. And then we see things show up, right? And I'm going to keep using that parallel, both for us and for families. And then it continues to feed back around. So are we doing, in year one, in year two, and even in year three, have we managed to shift the world completely? And I think maybe some of you can guess the answer to that. So I use this as kind of a fun slide to go, that saying, ain't nobody got time for that. Because time, as one of my evaluators always shares, is like the biggest culprit against getting some things done that we want to do. Engagement, relationships, being present, really holding the concerns of a family is something that takes time. And the system is not always the best enabling context for that. We didn't take away enough, I'm quite sure, to always allow for people to be who they themselves want to be and who we are asking within a model like this. So you end up seeing this tension between people wanting to do something unique and make a difference and being really pulled at times by caseload changes or someone leaving, or just, overwhelming time demands into back to business as usual. And fortunately, by having a structure like this, you have the opportunity to keep pressing on that. So another way that plays out is that, when the entire system hasn't changed, there's this sort of duality that workers continue to have to be, caseworkers have to be compliant with policy, procedure, deadlines, processes that are in the broader framework of what we're trying to do. But guess what? Here's what we're also trying to disrupt, that we don't want families coming and doing business as usual and just complying. I went to the class. I went to the group. We want to see both, all of us, in fact, making meaningful connections to shifting and doing this work differently. And that is most certainly a process. So I think I'm on target here. As I said, we're in year 3. We have 2 foster care agencies. They each have 30 cases assigned to them. We usually, we're a little over right now at 63 or 64 children enrolled in year 3. With anything that's as broad as this, you have to try to, go figure ground and look at the big picture, and then try to look at some very succinct areas where you're going to really, really press hard and focus over a quarter or a year. And in this particular year, like last year, the first 2 years, in fact, child and family team meetings were a primary focus. And while they continue to be, we're definitely seeing, because we have so many more cases reaching that transition phase of about to close and exit care, transition planning for families and children is a real priority. Communication, because we are a team between members and between people both at the table and outside the table that need to understand what's going on for unique families, but also amongst each other. I think communication in a program like this is an ongoing weekly, daily challenge. So far, 7 children have returned home, and 1 child is now in the process of adoption, which takes a bit longer in our state. And so I wanted to just show you a slide I think that we borrowed from 0 to 3 that shows a little bit about where court teams are across the country. I mentioned some things about sustainability or expansion, and right now we are limited in Cook County. I cannot today on this day speak to any specific plans for expansion, although I'm hopeful that that would be the way we would go as a state. You know, there's states such as Arizona, Florida, that have managed to get sites, multiple sites within their state. Right now, we only have the one. So I think there's a for more information type slide, which I would really recommend just going to 0 to 3 and looking for safe baby court teams. There's also the Quality Improvement Center for research on infant toddler court teams. Those two, I think, will tell you a lot about the court team model, and then, of course, the Clearinghouse can tell you a little bit about the other two models that I talked about. And I hit my target, Madison, to open it up and have lots of time for discussion. And maybe if I rushed too much and didn't make sense at any point in time. So at this point, I'll turn it back over to Madison to help us facilitate some questions.
Yeah, thank you so much, Dr. Mann. And like she said, please send in any questions you might have. I'm monitoring that right now. But just to get us started, Dr. Mann, I'm wondering if you can talk more about the actual creation of the court teams here in Illinois. I know the First Lady of Illinois at the time was involved in it, but I guess the question is, how did you sell this program? What beyond the, you know, a presentation like this was involved in its creation?
Well, I sometimes jokingly refer to myself as the director of marketing. I will say that it was a fairly easy sell. You know, we had supportive leadership in, even though we've had, you know, multiple directors over the course of time from the waiver to today. At the point in time that we launched, we're ready to launch, that particular director, which at the time was George Sheldon, came out of Florida, which has a heavy presence of court team approaches. So he was familiar already with the work. Our evaluator had already been talking with Judge Martin about an approach such as this, and she knew also from her national network of the work and had expressed interest. So it really, in some ways, you know, of course there were nuances and such to do it, but because we had the waiver in place, contracts were already in place for the interventions, for the primary interventions that were going to be used. The assessment process was in year 3 or 4. So a lot of infrastructure was already in place for us. And so our technical assistant from 0 to 3 felt like we were in a very different place than most folks were. We still had to, of course, identify agencies that would have an interest in taking that next step with us. But we had been working with them through the IB3 program for multiple years as well. So I would say the waiver helped us tremendously to have a lot of ground established that made taking that next step very logical and probably less challenging than I'm very aware some of my colleagues have had in other states.
And it sounds like this is very much a partnership type of team. You're bringing together a lot of different agencies. You're bringing together different systems within the larger court system. Can you speak a little bit about what, if any, resistance you had to this? Were there some folks who were like, you know, as you said, might have been like, we don't have time for that, or there might have been folks who said, like, this should not be a priority, or can you speak a little bit more on that?
Sure. I could talk about that for the next couple of days if you'd like. So, yeah, I mean, you know, I tell one of my staff that once you accept that all problems all the time is what you do, your life becomes quite normal. And you have people, challenges can take many forms. If we think about it from a trauma perspective, people have perceived some risk or threat. And sometimes that's as simple as change, right? When you think about, one of my caseworkers said to me in a very positive way, she said, you know, one of the things I love about court team is I really get to know the people that I work with. And that's a positive from her perspective. She knows everyone's name. She sees people repeatedly. some people don't want to know everybody that they work with. They want to see you, one and done, and I may see you again 6 months, 9 months from now. So there's an interpersonal quality that I think raises challenges that some people embrace and some people find to be more threatening, if you will, than others. I think there's the multidisciplinary approach. I can't say enough about that one. The fact that we have different training, and it's not even the parallel lanes of casework and clinical work, or people coming at clinical work from different perspectives. You're talking about being trained in the law, which can teach people to be very adversarial, and this relational, social worky, infant mental health kind of perspective. One of the things that I will say has, with everything that I would call a challenge, there have been amazing ways that things have shown up. So one of my favorites, one of our attorneys out of the state's attorney's office had a new staff member coming on, and he asked us to do a kind of mid-year training with them to help onboard. And his feedback was, well, I can handle the stuff on attachment. So that's a great example of how, you could just never know how things are going to show up, where you would think you might see, people being either less knowledgeable or less coming from the same frame that you might be coming from a clinical perspective. Weird things in a tangled way show up, and that can really play itself out in many different ways. It can play itself out in ways of the clinical team learning to have to speak about their work differently, and I mean this at a couple of different levels. I mean having to learn when you're engaging a foster parent, for example, or you're engaging a parent in something like a child-parent psychotherapy, how do you use more normalizing language to help them understand the thing it is that you're going to be doing? I talk a lot when I teach and supervise around how do you translate this for the audience that you're about to speak to. And so that becomes important really for all the different members of the system who either are coming from a different lane or completely different training. So we have to make our language accessible to people at its simplest. And we have to not assume that people understand our acronyms or what we're trying to do, because all of this becomes important if we're in fact trying to get people on the proverbial same page, that we're supporting a family and moving in a common direction and not pulling at a family so that they're feeling like people want different things of them at the same time, or asking very, very different things of them that aren't aligned with each other. I hope that answered that.
Yeah, great. Thank you so much. And then another question I had, just actually from me, obviously this is early childhood court teams. It is the 0 to 3, but I'm wondering what, if any, supports there are for older children who enter into the foster care system that either take some of what y'all operate on within your team or are other trauma-informed work. Just thinking about those kids who are outside of your age range.
So I think I will say this from two different perspectives. I've heard colleagues say in other sites nationally, as well as here for our own presiding judge, that people do tend to really like this way of doing work, and they hope to take at least the philosophy or thinking into other places. So one of the ways specifically that our judge is trying to do that, she invited maybe 5 or 6 other judges to our annual court team training. And so I think it's through some of the training initiatives where we can bring information about trauma, ACEs, et cetera, 0 to 3 work to other parties that we can at least begin to maybe think about moving that needle. It's not exactly the same as having all of the other systems instructors and community practice coordinators and the many, many other tools that go with this work that we don't have time to go into, but it is a shift in the right direction. I will say to you that we have a colleague who's trained us down in Florida, Judge Hope Bristol, who talks about being the judge presiding over a baby court and a non-baby court. And so even as much as she fully embodies the work, there are those challenges of stepping from one room to the other, if you will. So it's more than a notion to make it happen in its fullest. But I know that the folks at 0 to 3 are very much interested in what ways they might be able to help folks think about that, at least some of the components in a family first kind of modality.
Great, thank you so much. Another question we had was, you mentioned that this is the 6th and final year. Will these programs continue post the end of this demonstration project, or, if so, how will they be funded, or how do you anticipate them potentially evolving?
That's an excellent question. I want to be super clear about that. So IB3, which was the waiver that Baby Court was built on, will end. All waivers, federal waivers, will end September 30th, 2019 across the nation. We've been planning for sustainability for all of the previous fiscal year, FY19, and even before. And I'm so proud of the fact that all components of our IB3 waiver continue to exist. So those contracts continue. They're being managed slightly differently, and I'm not going to try to go into the particulars of that. But the nurturing parenting for caregivers, the nurturing parenting for birth parents, child parent psychotherapy, and the assessment processes all continue. And in fact, we're very, very proud of the fact that the assessment processes are now statewide. And through Family First, we think we're going to be able to expand, if not both interventions, certainly nurturing parenting will be one of the beginning interventions that we would hope would move forward through the Family First work and be done even beyond placement with our intact family services as well. So very, very proud of that. So keep in mind, Baby Court is not ending on September 30. It's just in year 3, and it's going to keep on rolling, but it continues to benefit from that foundation that was laid in the IB3 program.
Great, thank you. And we had someone ask if they could see the 12 core components again, so you'll see me flipping through the screen there for y'all.
Okay, thank you for doing that.
Yeah, because I think that's what their question was based on. So, okay, so there's that for the folks that wanted to look at it. You mentioned
Can I mention one other thing, Madison?
Oh, yeah, please.
So one of the things that happens within these is that you're constantly trying to take things to the next level. You cannot do all of this. Like day one, you're doing it all, and you're doing it all well. So I'm going to mention number 7, foster parents, mentors, and extended families. We had the wonderful benefit of attending the cross-site meeting for Baby Court was here in Chicago last month in August. And one of my favorite pieces of that 3-day meeting was the fact that it launched with some folks who had become mentors. They themselves had one time been involved in a Baby Court situation, and they now were employed by their local county's Baby Court, and they were supporting other parents as coaches and navigators. I've always been inspired by that. I continue to be, and that's something that ours is looking forward to trying to do. But I'm mentioning it not only for the particulars of that particular item on number 7 about mentors, but it just really shows how work like this in program development is very much stair steps. So I just wanted to mention that. I'm sorry.
No, thank you so much. Another question we have is, you mentioned that you've met with folks who this isn't their regular court, or you've trained other folks on some of the methods you utilize. So can you talk a little bit more about the expansion of that training and technical assistance aspect? Do you foresee that sort of being, centered just within your courtroom, or would you hope to see it replicated in other courtrooms? Is that a goal or a long-term vision? How is that being implemented?
So it's really, for me at least, there's 2 things that come to mind in that question. So certainly, child development or trauma or any of that stuff, I think, I personally have done trainings on that kind of work for years and years, and we continue to do it both in and out of the court. And some of my colleagues in the court have been asking for, as an example, one of our colleagues that's worked with our Baby Court is Susan Blumenfeld, who's done work on domestic violence, and some of you may know her. She may be on the call for all I know. But she has been asked to do work for other, just outside of court teams for the courts. So I think there's that piece of it. But the other term that you used was technical assistance, and 0 to 3 provides ours. And I know that if we move outside of Cook County to any other county, we would use 0 to 3's technical assistance, which is number 11, which would offer that new work, or excuse me, the new court / county that would be doing it, that support from the 0 to 3 model, who really is the owners of this model at this point. So I would be happy, and I know our team would be supportive of that, but we would not be the TA. They would be the TA. So just wanted to make sure there was some clarity around that. So certainly we do training as requested and as we're able to. I might add, we're not always able to, but we're not the TA for the model. We receive TA assistance for the model.
Great, thank you so much. And then another question we have is, how are parents introduced to / made to understand this approach and model versus that of a more, quote, traditional family courtroom?
I love that question, and if I'd done this with my team, which we usually do, that would have been answered, and I forgot to really offer specifics, so thank you, whoever provided that question. So we are, when we meet our families, we are very fortunate because of our close working relationship with our child protection unit to be there, hopefully right there at that first court hearing. And so we're there we have a packet that's a welcome and orientation. They, of course, would also talk about that with their attorney. And we really go through, here's what it is and what you can expect. Now, you can imagine that that's probably one of the most overwhelming days at its best for a family. If any of us was faced with that circumstance, the stress level alone would probably foreclose our ability to be able to fully hear anything anybody said. We might take in a half of a sentence if we, on that particular day. And if we happen to be high or any other, thing that compromised our ability to listen to what was being said, you have even more of a challenge. So you really have to think about this as being a process that, because of the frequency of contact, because we're going to see them again in 14 days and then in 40 days and continuing to meet with them monthly, that let's call it the socialization process and the reinforcement, restatement of what we do and how we do it differently. The fact that when they go to court, by the way, on the first day, the judge is not going to be sitting up high on a bench. She's stuff on a robe, but she'll be at a table equal and balanced with the rest of the members of the court. She will be talking to mom directly, which is probably a different experience if they've ever had other court experiences. I think the tone of the court attempts to be more therapeutic, not always possible, but that is a goal of the Safe Baby Court Team model, is to have a more therapeutic court environment and not as adversarial and fighting as one might see in other courts. And so in the end, you see things like we see in case closure, people bringing cake and balloons and celebrating, and family testimonials about how this team of people has helped them on this journey at one of the most difficult hours of their life. And fortunately, we have now had that experience several times. And so, it's again, not always perfect. Certainly some challenges, but and particularly whether in any case they were going to be within particular hearings. But from the moment they meet to the moment they leave us, we are continuing to try to walk on this journey with them.
So it sounds like there's a great deal of support for families and for birth parents, and so this question might be a little bit more complicated than one or the other. But another one we have is, would you say that the overall goal of the court is reunification or permanency?
Love that question. Yeah. If you see it's actually 3. So permanence for children, because it's the first 1,000 days are the most critical in a child's developing brain and development period. So that's one of those, when you say prioritizing the needs, we try to keep that 1,000-day, that concept alive for the members of the court in little ways. So, for example, when you receive a child and family team summary, when the judge does and the rest of the members of the court receive it, it has how long has this child been in care at the top every time, so that we don't lose sight of the fact that, hey, in our adult lives, was it just another year? But, In their baby lives, that means a lot. So because of that, being the primary, prioritizing that developmental period, all forms of permanence have to be considered. And that is a shift of really primary and gigantic shift in worldview for the courts, which can be fairly adult-focused, focused on adult issues, problems, and needs, and adult, chances, and all of those things. Those things aren't gone, but you constantly have that voice of where's the baby, keeping the baby at the table, literally and figuratively. So, concurrent planning you see on here as item number 6. And concurrent planning really should be talked about from day one. And there's therapeutic ways to do that, and there's really concrete ways to do that. And sometimes we've got to struggle around our best approaches to doing that in a more therapeutic way. Basically, any of us who have children of any age probably have thought about, what if something happened to me? Who would I want to care for my children? But along the way, for the parent who's walking through a child welfare involved process, they're thinking that if we're thinking about the care plan for the children, we should be thinking about things like, okay, so your child now at 6 months needs this developmental therapy or speech therapy or this care plan. How are you thinking about, taking that on or participating in that? And parents, and we've had limited experience. We learn more from our TAs about the national experience. When you allow parents voice and representation, not only legally, but literally to represent their ideas and their story to this team, they may come to their own decisions about wanting something different for their child other than reunification, and literally being able to make that heartbreaking decision that they cannot do this right now. So adoption, subsidized guardianship, and reunification are all options for permanence. In the national data, and so far in our data, reunification is our number one outcome. But we would expect, and you'll see this if you look at the video, I think the national data finds the reunification to be in the 60s, maybe around 62%. But when I quote data off the top of my head, it is always to be suspect. So.
Thank you. I'm going to close with just one more question, folks, but if you have more, please feel free to type those in and I'll collect them and pass them along to Dr. Mann. But our closing question is, are all families with children within the age room automatically asked if they would like to be in the court, or is there another process through which they're introduced?
They are introduced because of the agencies that they're assigned to. So children who come into the 2 agencies that we work with in the targeted age range of 0 to 3 and who are not assigned to another court. In other words, if a child was born and their sister had been in care previously, and so they're assigned to Judge X, that family could not be eligible because you can't move them to a new court. But if a child is born and even if their case is closed and they don't have an active case, or they are the first time the families come to our attention, if they're in one of our 2 agencies between birth through the age of 3, that family could come in, as long as they didn't have more than 3 children too, because we're trying to keep our pool of candidates as broad as we possibly can. So if one family of 8 could wipe out our small numbers, so it's they would have to have, no more than 3 siblings total, 3 children in the family total.
Great. Thank you so much. Folks, just to respect everyone's time, we're going to close here. But as we said in the beginning, you'll be receiving some of the materials that Dr. Mann mentioned. I'll make sure to include the links that she mentioned, as well as surveys and recordings of the webinar. And please feel free to reach out to me or Dr. Mann if you have further questions. Dr. Mann, thank you so much for presenting this. It was great and so informative. And yeah, thank you.
Thank you. I will send you a handout, Madison, to go along with this as well.
Great, yeah, and folks, we'll make sure to include that in it as well. So again, thank you so much, everyone, and we hope to see you all at our next webinar. Thank you.
Thank you. Thanks, everybody. Really appreciate you.